Hello everyone, I am Dr. Shaurya. Today we'll be discussing about heart failure. So whenever we are talking about heart failure, either we can talk about right or we can talk about left or both. So whenever there is right heart failure, there is congestion in the venous system. Right heart receives blood via the inferior vena cava and superior vena cava. And so if a patient is not having adequate function of the right heart, there will be congestion of the venous side. So this will implicate that the patient has a big spleen because and patient will have a big liver and the liver may become pulsatile. Patient will have increase in the jugular venous pressure because of the congestion of the whole of the venous system. This blood is supposed to go out of the right ventricle towards the lung via the pulmonary artery, and via the pulmonary veins it enters the left atrium, and from left atrium it goes towards the left ventricle. If a patient will have failure of this left ventricle, there will be congestion in this system. That means the patient might present with acute pulmonary edema. To quantify this, we have a measure that is known as pulmonary capillary wedge pressure. So increase in PWCP is indicative of left heart failure, while hepatosplenomegaly, pulsatile liver, increase in JVP and bipedal edema is suggestive of right heart failure. So, what are the stages of development of heart failure? There are four stages: stage A, B, C, and D. It is a series of steps. So, what happens for step A, that is stage A, patient is just as at risk. Patient is hypertensive or diabetic or having dyslipidemia, but there is no overt signs and symptoms or any structural heart disease. So, for this, we just have to take care of the comorbidities. While we are talking about pre-heart failure, patient may not have any symptoms, but patient will have evidence of structural heart disease or increase in cardiac enzymes such as BNP. While if we talk about stage C patients will have both symptoms and signs and also structural heart disease. And stage 4 or stage D are patients with advanced heart failure. These are patients who will have recurrent hospitalizations and may need extra therapy other than the guideline based medical therapy. So, based on the ejection fraction, heart failure can be divided into three. One is HFrEF, second is HFmrEF, and third is HFrEF. HFrEF is reduced ejection fraction, MR is mildly reduced ejection fraction, PEF is preserved ejection fraction. So, in patients who are having HFrEF, we will see that patient will have signs and symptoms, but ejection fraction will be more than 50%. How can we again say it is heart failure? We will see that there is increase in cardiac enzymes such as BNP. Also, HFrEF is ejection fraction less than 40, 40 to 50 is HFmrEF, and HFrEF is more than 50. So, whenever we talk about a disease, there are certain markers for it. So, serological markers such as brain natriuretic peptide. The name is brain, but don't be confused. It comes from the cardiac ventricular myocyte. Then we have troponins, SST2, galactin, GDF13 are newer markers that have come up. So, whenever we talk about management of heart failure, we basically have four pillars. Fifth pillar is the extended pillar. While we talk about the main four pillars are ARNI, beta blocker, SGLT inhibitors, and spironolactone. ARNI, uh, ARNI's example is sacubitril valsartan. Beta blocker, we can give a cardioselective beta 1 blocker. SGLT2 inhibitors such as dapagliflozin. Spironolactone is a mineralocorticoid receptor antagonist, and then we have iron. So, these are some new drugs that have come up other than the four. ARNI we've already discussed. Vericiguat is a drug which increases the vasodilatory properties by stimulating the guanylyl cyclase enzyme. Then we have omecamtiv mecarbil. This is a drug that activates cardiac myosin selectively. So there is it can contract, but there is no increase in oxygen demand. So if the possibility of ischemia is decreased and the cardiac contractility is maintained. And then we have a non-steroidal MRA. Spironolactone is a steroidal MRA, but finerenone is a non-steroidal MRA, as evidenced by certain trials such as Fine Art and Figaro. Finerenone has come up as an add-on agent, but it is not the first-line agent that has been there. So the first line has to be ARNI while we talk about chronic heart failure. So a patient may have acute heart failure. That means the patient may have myocardial infarction and then LV may cease to function, and then there will be subsequent increase in the LA pressure, which will lead to acute pulmonary edema. So in patients with acute heart failure, our goal is just two things. One is to vasodilate, and second is to give patient adequate diuresis. So whenever we're talking about acute heart failure, just remember two things: give diuresis and vasodilate. And in patients with chronic heart failure, there is a remodeling that is going on in the cardiac myocytes. To prevent that, we have drugs such as ARNI. So chronic heart failure, we have to prevent remodeling. So ARNIs and beta blockers prevent remodeling. So stages wise, for stage A is to avoid risk factors, B is to block the neurohormones, C is go for the core 4 drugs, and 4 is devices or destination therapy. So here we can see in stage A, patient just needs risk factor control, while stage B, patient will have a requirement of neurohormonal axis improvement. We also have to discuss two more things. In patients who are having ejection fraction less than 35%, we have to suggest the patient to go for ICD if patient is beyond 40 days of MI. I mean, a patient had MI and myocardial infarction, and next 40 days, the ejection fraction has remained low, and now it has been more than 40 days, and ejection fraction has still remained low despite the patient receiving the four major pillars of heart failure therapy. We may have to take the patient up for ICD. And we have to also see that if patient is having QRS interval of more than 150, patient will have increased risk of arrhythmia such as ventricular tachycardia, which is a fatal arrhythmia. So we have to discuss about the possibility of a CRT. And stage D is palliation or device therapy. Or patient may need a cardiac transplant if patient is at stage D. Then what happened is because of this, Ronco came up with the classification of cardiorenal syndrome. Some patients were seen to have dysfunction of the kidney because of the heart, and vice versa. So 1 and 2 type are cardiorenal syndromes, and 3 and 4 are renocardiac syndrome. That means a patient who is having acute myocardial insult and now having AKI, patient is having cardiorenal syndrome. Then we have type 2, patient is having CHF, patient is having chronic heart disease that is leading to involvement of the kidney, that is type 2. Then we have renocardiac, a patient with acute renal dysfunction landing up with acute heart failure. And then we have type 4. Type 4 is chronic renocardiac. That means patient is having CKD and now patient is developing cardiac disease. And type 5 is a systemic disease that is affecting both cardiac and renal at the same time. So Ronco's classification is also important and sometimes asked in the entrance exam. So that wraps it up. Thank you for listening.